Welcome everyone. We've got Dr. Gil Carvalho from Nutrition Made Simple. His channel's about to cross over 100,000 subscribers, and I think it's awesome to have him on the show today. So welcome, Gil.
Thanks for having me.
So today we're hoping to go through diet, supplements, medications, fasting, a whole bunch of things to hopefully extend health span and lifespan. So I think we'll start off with diet, in particular, looking at popular diet myths. So Gil, what sort of things have you come across online that is quite prevalent that doesn't necessarily have that much evidence behind it?
Every day is a new one. There's by this point there's nothing I haven't seen. The only thing I joke that the only thing I haven't seen is the all junk food diet being promoted as healthy. Although that's already what most Americans are doing anyway. So, but we haven't seen that fitness trend. What are some really? Yeah, I mean, there's everything under the sun. We see a lot of on social media. I think things are separated into diet camps, and so people kind of find a diet that they like or that makes them feel better, and then there's this strong emotional attachment to the diet. And I think one thing that we see pretty consistently is this idea that the diet that I'm on is perfect for everything. There are no caveats, no shortcomings. When in reality, there's caveats to any diet. Any diet has issues and things that you have to look out for. So there's this diet exceptionalism that, my diet is perfect. And then people sometimes go so far that established risk factors are not a problem if you're on that diet. It just gets out of control. So as long as you're on I hear this from everyone. This is not like singling anybody out. I hear people on the very plant-based diet saying, as long as you're on this plant-based low-fat diet, your cholesterol, your triglycerides can be through the roof. It doesn't matter. You're protected. I see people on the low carb end of the spectrum doing the same thing. As long as you're low carb, ApoB and cholesterol don't matter. So this is almost like a religious level of belief that the diet is magically going to protect you against a risk factor that is, that raises risk for in every condition that has been looked at, in every condition that's been tested. So that I think is one thing that is prevalent and reproducible across diet camps, and that I think is a little dangerous. What else?
Well, just on that point, I completely agree. There's almost a little bit of tribalism, I think. But if people find a particular diet that works for them, it seems that they want to correlate that to everyone else, that since that diet worked for them, it's going to work for everyone. And I think it's great that some people have found a diet that works for them and that they're continuing their health journey, and I think that should be encouraged. But as you say, we can't just throw out the baby with the bathwater. We need to make sure that we're looking at the whole person. And if a particular diet is making, LDL cholesterol, ApoB go up, if it's, causing issues with blood sugar levels, I think we need to look at the whole picture and just, take a step back. And I found it online, I found it a little bit tricky to talk to some people about that. But I think you do a fantastic job on your channel about, presenting the entire the entire picture so that people can make up their own mind. And I think at the end of the day, that's all we can do, is just present people with the latest information, and it's up to them to make their own decision. So I'm curious what you see about that, what you think about that strategy.
I think that's a perfect articulation of the whole idea behind starting the channel. It was hello, says Joanna. Hi, Joanna. When I started the channel, that was the idea. It was just give people access to the information so that they can make their own informed decisions. It was, can we treat people like adults instead of just giving them sound bites and this kind of almost this rooting for a diet? And there's the vegan channel and the low carb channel and the high carb channel, and on each one of those the diet is perfect and everybody should do what I'm doing, and if you're not, you're missing out on something, or you're not right in the head. This type of almost a religious espousing of ideas. And so I thought what I thought was missing was precisely, here's what we know scientifically, and then based on that information, you decide whatever's right for you, and there isn't one right decision. I usually say that there's two types of success stories that I get from my viewers. One is, hey, I saw this video, I finally understood this concept, you explained it really well, and I understood that I was incurring in a risk that I didn't understand before, and so I changed my lifestyle to avoid that risk. That I would say is one type of success story. The other is somebody who says, I understand what you're saying, I understand the risk, but I still choose to accept that risk. To me, they're both success stories. One is not better than the other. In both cases, people are making informed decisions, and they understand the constraints and the different factors at play. So once I've given people the access to the information, the decision they make is out of my hands. It's not for me to say.
Yeah, and I completely agree. Like, so I've just brought up this comment from Stephen, because I think, Gil, you made a fantastic video where you went through one of Dr. Berg's videos looking at cholesterol and how Dr. Berg was breaking down the cholesterol profile. And I think,
Uh-huh.
do you just want to speak to that? Because I think you did a really good job explaining the pros and cons and actually what we should be looking at with the cholesterol profile.
Yeah. So one thing, we get a lot of requests from our viewers to comment on specific pieces of content. Can you talk about this video that Dr. So-and-so made? Can you talk about this blog that somebody wrote saying that, some idea? And so we get a lot of those types of requests. And honestly, those are my least favorite videos to make. I enjoy more making the other videos where I'm just kind of going over a specific question or a field. But once in a while, I kind of have this compromise. Every 10 or 20 videos, I'll make one of those videos that the audience requests a lot, and I'll go over something that dozens or hundreds of people are requesting the same piece of content. So this, at the time, was our most requested video. Was a video by Dr. Eric Berg, who I knew nothing about at the time, but we had dozens, if not hundreds, of different requests for the same video. So I went through it, and we kind of compared the claims made to the evidence, to the scientific evidence on cholesterol particle size versus particle number. And there were a number of misconceptions in the video. But it's interesting that Stephen says, is this the guy who hates Dr. Berg? I have nothing personal against him. He actually seems like a really nice guy. And I think I said that in the video, but I think it's a little inevitable that when you're commenting on a specific piece of content by someone specific, it's inevitable that people will see it as a direct attack on the individual. Even though we really, really tried to specifically say in the video, look, this is not a personal attack. There's nothing against him, but it's almost inevitable. People will see this as a clash, Dr. So-and-so against Dr. So-and-so. So nothing personal. And actually some of the thoughts that he put forward in that video, I've seen many other people kind of say the same thing, but it's just not supported by the majority of the evidence. So we just tried to show the evidence as say, look, this is what's out there. When you look at further analysis, when you look at more robust methodological approaches, it doesn't support this. So just beware. But it's not an attack on the individual or the channel. To this day, I'm not really familiar with the channel as a whole. That wasn't the goal. It wasn't, let's go attack this channel. It was just this video that viewers really want to have dissected or commented on. Does this reflect the evidence?
And that's exactly it. I think if we just focus in on what the evidence actually shows, then at the end of the day, it's just for people to make up their own minds. And that's all we're here to do. It's just to provide, the human clinical research so that people can make informed choices. And, that's exactly the approach that I use in the clinic. At the end of the day, it's the patient's life, it's their body. So I'm there to explain different processes that's happening in the body and what the potential treatment options would be. But at the end of the day, it's up to the patient to decide what they want to do. And it's that patient-centered approach. And that's exactly what we're trying to do on the channel. And that's one of the reasons why I really like your channel is you subscribe to that, where again, it's not your opinion per se, it's simply the evidence that matters. And I think that's really, really good. So on still continuing with the point of diets. So what are some of the fundamental things that you think make up a healthy, good diet?
So when we look at the evidence that's out there, the quote unquote diet that comes out as having the most evidence behind it is the Mediterranean diet, simply because these large clinical trials have been carried out looking at the Mediterranean diet, at least 3 big ones at this point, with hundreds to thousands of participants, conducted over years. And so no other diet crosses that bar. But that's kind of a tricky, that doesn't necessarily mean it's the best diet. It's a tricky, it would be an overstatement to say that. It reminds me of when in baseball, when they say team so-and-so won the World Series, when it's really only two countries that participate, right? The other 196 countries don't participate, but you're the World Series champion. So this is kind of similar. The vast majority of diets haven't been tested to that standard of these, large and long randomized trials. In a perfect world, or in a dream world, you'd have a massive trial like that with 5 or 10 different diets in parallel, carried out for a decade. But that's just not feasible in reality. These trials are massive endeavors. Logistically, financially, it's colossal to carry out a trial like this. So in reality, what we're going to have is we're going to have all of this mass of evidence that we then have to collate and kind of piece together and come up with some common themes. That's the trick in nutrition. And so what we see consistently across, whether it's observational studies, the cohort studies, the AKA epidemiology, whether it's interventional trials like clinical trials, RCTs, mechanistic data, population data like ecological, across the board, what you see the consistent patterns are that diets that are rich in fruits and vegetables, unprocessed plants, legumes, whole grains, nuts and seeds, things like that. Fatty fish has also great outcomes across the board. And so those things, dairy to some extent, depending on context, especially lean dairy. So those things would be like things that emerge consistently when you look at outcome data. So the health effect on humans of consuming food A, B, or C. And so then you piece that together. Other things that emerge also, an excessive sodium, added sodium, consistently associated with high blood pressure and higher cardiovascular disease risk. Alcohol, low to no alcohol in the diet. Consistently, you see unsaturated fats having better outcomes than saturated fats. And so you look across, you put all of this together, it gives you an idea of a pattern. Now, obviously, there's flexibility here. You could use these critical buttons to compose diets that are pretty different in terms of the macronutrients. You could design a diet that's higher carbohydrate or lower carbohydrate, with a higher fat or lower fat, that embodies these different principles. And so the Mediterranean diet does embody them, at least in its classical form, right? Nowadays, Mediterranean diet means whatever it means, whatever people are eating in the Mediterranean region. It's probably a lot of McDonald's and stuff like that, just like it is in the U.S. But classically, what's meant by Mediterranean diet is something that is plant-rich, some fatty fish, some dairy, olive oil, some lean meats, and so that's the bulk of the calories are coming from those foods. So it checks all those boxes. And other diets that are popular, other formulations that are popular, whether it's low carb, low fat, omnivore, all of these can be formulated in a way to check those boxes and to fit at the same time, check those boxes so they improve your odds of health, long and medium term, but also that aspect of personalizing and of tailoring the diet is very important because it gives the ability to put something together that works for me. Right? If I do better on a lower carb diet or on a higher carb diet, it's important that I design my diet so that it matches my personal preference, because at the end of the day, this is about sustainability. The best diet is a diet you can sustain. There's no point eating a picture perfect diet for a weekend and then falling off the wagon. It does nothing for you long term. So the trick is to find something that A, I can sustain and enjoy long term, and B, maximizes my my health potential and minimizes my risk.
Yeah, I completely agree with that. That it's the fundamentals that at the end of the day matter, and you can tweak how those fundamentals come into fruition in your diet. So, some people swear by the low carb diet or the low fat diet, and that's absolutely fine. We can, if we're using those fundamentals, then we can make sure that whatever diet seems to work for you, we can make sure that it still gives you those positive outcomes in terms of your cholesterol levels and, blood sugar levels. One of the things that you mentioned was whole grains. And I sometimes mention this on my channel, and people get a little bit cross with me because I think that there's a lot of people that talk about how whole grains are terrible, when actually the evidence doesn't show that. If anything, it's the opposite. So have you encountered this resistance against whole grains on your channel?
Some. I don't know every single motivation why people are convinced that they are so bad. I know that in some cases, people removed all grains from their diet, and their diet improves in different ways. But of course, that means you're removing all kinds of processed foods and ultra and refined grains, right? And so it would be like throwing away the entire nursery with the bathwater. So the problem with reconciling an anecdote and my personal experience with the body of evidence is that usually in an anecdote there are multiple moving pieces, and so the extrapolation to cause and effect is very tricky. So people remove grains from their diet, all grains, their health improves. They assume that all grains are damaging, and then if somebody's trying to establish this distinction between whole grains and refined grains, you get resistance. The other issue where I think this can be a little confusing is if you already have a metabolic issue at baseline, if you are a type 2 diabetic, for example, or type 1, and you eat something, I've seen cases like this, people who eat oatmeal and they have they have huge spikes of glycemia because they have an underlying issue in processing carbohydrate. So that's clearly an intolerance that's contextual for that individual. And it could be a matter of moderating. It could be a matter of laying off the whole grains until the underlying issue is resolved, or it could be a strategic issue of replacing some of the whole grains with other health promoting foods. But what we should try to avoid is the logical leap that because whole grains pose an issue for me, that they must be bad for humans. It's a bit like saying, when I eat strawberries, I have an allergic reaction, therefore strawberries are damaging for humanity. Or seafood, same logic, right? There are contextual intolerances that are real and that should be taken seriously and not dismissed, but we can't extrapolate to, oh, this food is bad for people.
Yeah, I agree. It comes back to the idea of personalizing the diet. So when I see a patient in the clinic, I'm not just prescribing one diet for everyone. It's trying to come up with particular strategies that are long term. And what we typically try and do is focus in on small tweaks and just focus on one or two of those small tweaks so that we can move forward to an overall healthy diet. And with those tweaks, what we're looking for is adhering to those fundamentals, but making sure that those tweaks fit in with a patient's lifestyle, their culture, their tastes, because it needs to be over the long term. If, like you said, if we're following a healthy diet for one weekend, that's not going to change our outcomes. What will change outcomes is following a healthy diet for years and years into the future. That is what really matters. So again, some people find a low carb diet fantastic for them, and that's great, so long as we are still following those fundamentals and making sure that at the end of the day, we are going to be, lowering our heart attack risk, lowering our stroke risk, making sure that we're getting enough protein to hold on to our muscle, but not too much protein that we're causing other adverse events. So yeah, on that point of protein though, this was actually a question from one of the viewers. The ideal protein intake to balance holding on to muscle versus the other downsides of having too much protein. So curious to hear your thoughts on that.
This is an area where my sense is that there's some legitimate scientific controversy or disagreement. Particularly, I've seen Christopher Gardner, who's a professor at Stanford for people who don't know him, and he does a lot of dietary trials. And Stuart Phillips is a professor at McMaster, and he's a protein researcher. And I've seen some disagreement between them on the ideal dose. I'm actually having both of them on my channel in the near future, so I'm definitely going to ask them about that among other things. So the RDA is 0.8 grams of protein per kilo of body weight per day, and that's calculated to fulfill the requirements for 97.5% of the population. Now that's requirements assuming no special needs. So there's actually a really interesting meta-analysis published, I think 2 years ago, that looked at the effect of adding extra protein above VRDA, above zero 0.8. And what they found was that for most people, they didn't see a statistical benefit. But for specific situations, and there were 3 that I remember where there was a benefit of adding more protein, of going higher. One was if people were in a caloric deficit, so they were trying to lose weight. There, they saw benefit of having more protein, specifically to hold on to your muscle mass, to not lose too much muscle mass as you're losing fat mass. The second situation was an older population, above, I forget if it was above 50 maybe, because the anabolism is a little less efficient above a certain age, and so having a little bit more protein helps. And the third group was, I don't know if it was people who were entirely plant-based, may also benefit from eating a little bit more protein. So basically, there are some specific situations, some specific contexts where going above 0.8 was beneficial. Some researchers, I think Stuart Phillips is of the opinion that pretty much everybody should go a little higher. I've heard some people say 1.2. Stuart Phillips has this meta-analysis where he calculates that about 1.6, so twice the RDA, is where the benefit of protein would max out for hypertrophy, for muscle gain. So, for people who are lifting weights and trying to put on muscle, that would be kind of the goal, to be above, ballpark 1.6. And so that's kind of the brackets where I see the debate occurring.
Yeah, I'm sort of the same opinions as you, that for most people, the ideal protein intake would be sort of somewhere between 0.8 and 1 gram per body weight per kilogram of body weight. But for my older adults that I see in the clinic, particularly over the age of 60, I often find that they are not having enough protein in their diet. And over 60, that's such a crucial time, because we need to stop muscle decline. We want to prevent the need for rest homes and private hospitals, and we want to make sure that people are independent when they get older. So over the age of 60, I really encourage my patients to start eating more protein, but I want them to be eating sort of lean sources of protein. So, chicken, also things like fatty fish. Red meat is, I think, okay in smallish quantities, but it's more the other sources of protein that I really try and encourage them to eat. But you're absolutely correct that for bodybuilders, it seems to be a bit more sort of closer to the 1.6. And it's interesting that we've got this rough general consensus, I think, with the sort of fundamentals of a healthy diet and how much protein we should be having. On the point of red meat, though, the carnivore diet has really kicked off recently, and I must admit, I haven't necessarily looked specifically at the evidence for the carnivore diet. I've not come across any studies that compare, say, the carnivore diet to a Mediterranean diet, but curious to hear what your thoughts are and how this diet sort of kicked off.
So just to wrap up with the protein, there are studies that look at, for example, for body composition. Some studies indicated even higher range. So they go up to 3 or even higher, 3 grams of protein per kilo per day for those specific benefits of body composition. But most of the debate I see for the majority of the population is in that around 1, give or take half a milligram, half a gram. My experience, I have viewers who say that they started eating only meat, that they eliminated all the plants from their diet. In most cases, that the viewers are sharing with me and asking questions and kind of reporting their experience, there seems to be a large cohort of people who had gastrointestinal issues to begin with, and then they eliminated some of their sources of fiber, or in some cases close to all, and they report some improvement. That is not super surprising to me. I've had not only does the evidence and the clinical practice in gastroenterology have precedent for that, but I've had, anecdotally, in my own family, I've had at least 2 people very close to me that had devastating gastrointestinal issues, and they also had a very restricted diet at that kind of acute period. And so in gastroenterology, it's called the low FODMAP diet, and there are some others where a restriction of some foods, specifically some forms of fiber, are indicated in these acute periods where people have intolerances and an inability to digest these foods. Depending on the condition, it could be an imbalance of the microbiome. In IBS, for example, that's thought to be one of the underlying issues. And so, yeah, there's large precedent for a reduction in variety, and specifically a reduction in certain types of fiber to give you some symptomatic relief, because your digestion of these foods is impaired. And so the pain, the bloating, the excessive gas, and all these symptoms tend to improve. And the other thing is that a lot of gastrointestinal conditions can manifest in very pleiotropic ways. So you can have immune system manifestations, you can have skin manifestations, you can have mood manifestations. So a lot of things can be affected by gastrointestinal health. So that's something that I've seen a lot of my viewers report. And just to give you kind of in my experience, specifically, both in the literature and talking to gastroenterologists, and what I also saw anecdotally in my family members, was that was necessary. So you start with that restriction to control the symptoms and to arrive at a situation where you pretty much have a baseline where things are, you don't have these devastating symptoms to begin with. You arrive at that baseline, let's call, and then you start. Then the second phase is you need a proper diagnosis of what the underlying condition is. Then you need a treatment plan if there's an underlying issue, if there's SIBO or if there's IBD, like inflammatory bowel. You have to fix the underlying issue first. Once the underlying issue is under control, or if it's IBS, there is no underlying issue, it's just a functional issue, then there's a phase of gradual and careful reintroduction of foods that can both identify the problem foods, and this is very interesting and very paradigm shifting, it can shift the balance of the microbiome, and it can actually solve the problem eventually. So that's what I saw with my family members, that gradual reintroduction allowed them to tolerate those foods again. And I mean, these were devastating symptoms, quality of life completely on the floor for years, and now they can eat all the foods that they couldn't tolerate before. Now, we have to be careful with these anecdotes. I'm not saying that that's going to be the case for everybody. I'm saying that is possible, at least in some cases. So the important thing, I think, is to seek proper diagnosis so you understand what condition is underlying, and see what options there are in terms of either treatment or management.
Yeah, and I think you bring up a really interesting point about the idea that the carnivore diet, it is a type of the low FODMAP diet, and the low FODMAP diet is a diet that I often prescribe to patients that do have irritable bowel syndrome, and on that particular diet they have wonderful results. And I think the difference here, though, is that I make sure that if a patient is going on a low FODMAP diet, it's done via a dietitian, because we need to make sure that patients are still getting all of their micronutrients that they need, and we're still making sure that their cholesterol levels are going to be fine, their blood sugar levels are going to be fine. So the concern that I've got is that, yes, some people with irritable bowel syndrome, they might have really awesome results initially with the carnivore diet, and that possibly feeds into the debate online, where people anecdotally say, yeah, the carnivore diet's awesome, I feel amazing, because they probably do, because it's a low FODMAP diet. The concern that I've got is the long-term effects of this diet, because it seems that the carnivore community, they seem to throw out the idea of ApoB, of LDL cholesterol, that they don't necessarily matter, when actually that seems to be the complete opposite when you have a look at the overwhelming amount of evidence that we've got. So I agree with you that, in some instances, the carnivore diet initially can be an introductory way into the low FODMAP diet, but I just caution people that you'd want to seek a dietitian's advice on this to try and start to reintroduce foods, as you suggested. That the evidence that we've got so far is that the long-term effects of the carnivore diet is probably not the one to go for.
What's funny? I mean, we get this, being on social media, we get the anecdotes, And honestly, I get them from every corner of the nutrition world. And so sometimes it's, if I talk about uh, good health outcomes of fish, I'll have people who are vegans and who are convinced that all animal foods are toxic. They'll complain in the comments and they'll say, "Look, I went vegan and look at all the amazing benefits I experienced." Um, One thing that I was looking at, and if you've been around nutrition and the social media nutrition for a little while longer, one thing that used to be the source of just amazing anecdotes back actually a couple of decades ago, but so before social media, but it was the white rice and sugar diet. This was something that was initially introduced. I think it's called the Kempner diet, and some people call it that because I think Walter Kempner is the guy that came up with it. Initially, the idea was to manage very blood pressure levels that were out of control. So he would put people on these diets. They were essentially white rice, a lot of table sugar, maybe some fruit juice, but that was the bulk of their calories were coming from those foods. And there were mind blowing anecdotes. The blood pressure was coming down. They could see clearly. They could they were feeling better. The weight loss, the diabetes went away. All of these things, and you tend to see these things consistently when you're exposed to the different camps. I hear the same anecdotes from people who vouch for completely different diets, whether it's I eliminated all the animal products, I eliminated all the plant products, I eliminated all the carbohydrates, I went super low fat. I get the same anecdotes from people for different dietary changes. And so I'm not saying I believe every one of them. I'm not saying that they're making it up at all. I think the problem is the interpretation, that we tend to assume that the foods that I started eating are great and the foods that I eliminated are poison, when we are only exposed to one class of anecdotes, right? Whereas I think we have much more plausible explanations for these anecdotes across these different diets. I'll just throw out two or three. Number one, all of these patterns eliminate ultra processed foods, which for most people going in are going to be the majority, or a chunk of their calories are coming from junk food. They've eliminated those to go on these diets, whatever the diet is. So weight loss is going to come almost automatically by virtue of limiting your options and by eating whole foods, whatever they are. So right there, you're going to have an improvement in body weight. You're going to have an improvement in glucose metabolism that comes basically as a consequence of almost automatically when you lose a substantial amount of weight. Inflammatory markers come down when you lose a substantial amount of weight. You're going to feel better, obviously psychologically as well as physically. And so I think we just have to cultivate a little bit of discipline of not making these logical leaps that the thing that made me feel better acutely, or it could even be a couple of years, must be healthy in all contexts. And the things that I eliminated must be unhealthy. A lot of times it's more complicated than that.
Yeah. No, I completely agree. On the point of weight loss, so this is one thing that I'm quite passionate about in the clinic, and I'm passionate because we've now got treatment options that really help patients. And I sort of want to bring this up because with the diet studies over a long period of time, so I'm talking sort of 1 to 2 years, it doesn't look like there's any one particular diet that's overwhelmingly best. That at the end of the day, it's coming up with a diet that works for you and that actually puts you into a calorie deficit. But the almost the sad thing though is that for most people, they'll lose 2 or 3 kilograms over a year or two, because you'll have this big dip in weight, then generally you'll start to put it back on until you reach that plateau again. And we've now got treatment options in terms of medications that seem to really shift weight for patients. So I've been prescribing a class of medication called GLP-1, which significantly reduces patients' appetites. And it was originally designed for type 2 diabetics. And we're getting amazing results. It just means that patients can actually take charge of their life again, where food isn't consuming their life. And when they do choose to eat, they're choosing to eat really healthy foods because they just simply don't have this ravenous hunger anymore. So I firmly believe that diet and exercise always come number one with with diet and with trying to lose weight. But at the end of the day, for most people, diet and exercise don't sustainably shift that weight. The medications in conjunction with the diet and exercise seem to. So I'm curious to see what your thoughts are on sort of the just using diet alone to try and lose weight.
I agree with that general overview. When you look at meta-analyses, looking at different diets and putting all this stuff together, you generally see two patterns. One is that no diet emerges clearly as superior, and the other, exactly as you said, is kind of a negative note, is that all diets do equally poorly in the long run. You tend to see an initial weight loss, and then you kind of see this petering up of people putting weight back on. Another thing that's very interesting that I've noticed in a lot of these trials is when the trials show something that's the waterfall plot. For the audience, it's when you plot the results, not just the average, but you show every single participant, whether they lost weight or gained weight. You see massive inter-individual variation, and you see that some people, for example, a lot of these trials compare low fat to low carb diets for weight loss, and you see that some people did really well on the low carb, and some people did really poorly on low carb, and the same thing for low fat, right? So this is suggesting, back to the point that you were making earlier, that the diets are not superior populationally, but for a specific individual, there could be a clear superiority of one diet formulation. And that could be a personal preference, like the person just prefers or is able to stick to the diet better, or it could be something physiological where it just works better energetically. Whatever the mechanistic explanation is, I'm compelled that there is this individual variation, and that finding something that you can stick with and that you can lose weight and keep the weight off is crucial. And on the point of having the drugs not as a crutch, but as an option, as a tool in the toolbox, I completely agree. I mean, that's why these things are developed, and they're used scrupulously. You're not going to pass them out like candy. But when it makes sense and when it can help people and nudge people to have success that they could otherwise not get just with lifestyle, I think it makes total sense. It's the same thing in cardiovascular disease. A lot of people are so fascinated with the potential of lifestyle that they deny any role of statin or any intervention, something like that. Just fix your diet and just exercise. And that's too simplistic. Yes, most people can have healthy lipids just with a healthy diet, but some people can't. There are genetic constraints. Also, there are psychological or social constraints. A lot of people, even if they have the physiological ability, are not going to do it. Whether it's because it's too hard to make a change, or just social or family pressure. There's all these contexts that are going to determine how we eat, whether we exercise or not. In the real world, yes, there's a group of people that are going to be able to turn their life around just with lifestyle, and there are some people that are not. And so if you don't offer all of the possibilities and use them criteriously when they fit, I think you're leaving benefits on the table.
Yeah, and I think if people can take anything from the discussion that we're having, there's no one diet that works for everyone. It is about personalization, but it's making sure that we do try and stick to those core fundamentals. We can tweak how we implement those core fundamentals to the diet to make sure that overall it's a healthy diet. But we need to make sure that whatever diet you're sticking with, it's for the long term, because it's the long term where you get those benefits. A couple of other questions that came up when I was planning this live stream was about eggs and seed oils. So I'm curious to hear your opinion about whether eggs are healthy or unhealthy, because the literature seems to flip-flop a little bit, particularly on eggs.
I think what's difficult is to give people a simple answer. Like, everybody wants to hear that eggs are either poison or completely fine in every context, no matter the amount. And the science doesn't support either of those views. You can have a healthy dietary pattern that includes some eggs, but at the same time being aware that, yes, I think the question that arises is whether dietary cholesterol affects serum cholesterol. This is something that people ask a lot. The answer is it can, but it's contextual. So eggs can increase your serum cholesterol, but it's not a huge effect, and it's only in a specific range of the distribution. So if your intake of dietary cholesterol is low, you will see an effect as you increase dietary cholesterol. But once your intake is higher, which is the case for a lot of people in Western societies, just adding more eggs on top is not going to make a difference. So that explains some of the heterogeneity in the results in the literature. So I would say, just to kind of answer it briefly, if you're a pretty healthy person, healthy diet overall, and you like to eat some eggs here and there, I don't see a major issue. On the other end of the spectrum, if you're somebody who has just raging dyslipidemia, and you're having, 6 eggs a day because you think you need the protein and you can't get it anywhere else, there might be some room for improvement there, some tweaks. That's the kind of the quick answer.
Yeah, I agree. I think it's if we just try and boil diets down to one particular ingredient, it can be really difficult to give people a direct answer, because that's kind of missing the bigger picture, which is overall, are you sticking to those core fundamentals of a healthy diet? And eggs can absolutely be a part of a healthy diet. It's the whole picture, I think, that matters. So if I saw patients in the clinic that ask me about eggs, I say absolutely, they can be a part of a healthy diet. But what else is in your diet? When are you eating? What's the makeup of your diet? Are you exercising? It's the whole picture that actually matters. And I'm not too sure if we should get into the seed oil stuff, because I've seen a lot of chatter about this online, but I've not seen any evidence that seed oils are bad. If anything, they're generally a good thing for the body. So, yeah, curious to hear your thoughts on that.
Yeah, I'm happy to give you to give you the elevator pitch, or the quick TLDR on it, and get ready for the hate, the angry comments. I don't know why seed oils have become such an emotional thing on the internet, but I guess it's common to a lot of these topics in nutrition. People can get very emotional about these things. The truth is, when you look at the evidence kind of systematically, just overwhelmingly positive outcomes for these unsaturated fats, particularly from these N6 richer oils. Depends what you're comparing them to, right? What you're replacing. If you're comparing to olive oil or one of these things, that you generally see about a tie. There's no clear superiority there, whether it's cohort studies looking at long-term, or whether it's shorter-term experiments looking at risk factor serum markers. And when you're comparing it to more saturated fat, richer foods, butter or lard or something like that, you tend to see a clear superiority of the unsaturated fats, whether it's olive oil or whether it's canola oil. They all pretty much perform more or less equivalently. The inflammation, I guess, just to touch on it briefly, one of the main question I get is, are seed oils inflammatory? And this has now become repeated so many times that I now see people with MDs and PhDs just saying these oils are inflammatory, avoid them all. And sometimes I ask, like, what's the evidence? And I never get a straight answer. Either they don't reply, or they come up with some kind of circuitous logic. But when you look at the actual measurements of inflammatory markers with intake, this is such a rigorous experiment that you can just do a clinical trial. You give people different fats and different oils, and you measure inflammatory markers. It's not ambiguous. And you consistently don't see an effect. They're not anti-inflammatory either. You just don't see an effect either way of seed oils. And so I think one of the reasons that people assume they are pro-inflammatory is the biochemical pathway. Linoleic acid is one of the precursor essentially to arachidonic acid. And so this pathway has some pro-inflammatory downstream molecules. But this is just an example of what we call mechanistic speculation, where we look at a biochemical pathway and we assume the systems level effect. In reality, in vivo, you can vary the intake of linoleic acid by several fold, up or down, and you see little to no change in arachidonic acid levels. So it just doesn't pan out in vivo. The pathway is not this, passive thing where no matter how much LA you put in, the AA is just going to immediately mirror it. The body's a little smarter than that, and it titrates things. So the bottom line is, you look at the inflammatory markers; they don't change across the the body of literature. So there's no way around that.
Yeah. Yeah, I've got nothing to add. I completely agree. I don't think we need to indulge seed oils anymore. The last thing about diet that I do want to touch on is fiber. So we mentioned how for some patients with irritable bowel syndrome, fiber can actually be one of the worst things for them. That if once they start going onto a low FODMAP diet, their symptoms resolve. But for the vast majority of patients, I think the evidence is overwhelming that we do want to be increasing fiber in the diet, and that's through fruits, vegetables, and I actually use a supplement as well, psyllium husk, which I add to my morning smoothie. So yeah, have you got any particular thoughts around fiber for the vast majority of people?
The evidence is overwhelming that fiber is beneficial, or we should say sources of fiber, foods that are rich in fiber. If you're eating fiber from processed cereal, artificial cereal, and it says contains fiber, I don't know about that, but foods that naturally contain fiber. I would throw in whole grains are a great source of fiber as well. The body of evidence supporting the benefits of fiber is just overwhelming, whether it's observational or interventional. There are meta-analyses with dozens of randomized controlled trials. Improves your lipids, helps with maintain body weight, improves glucose metabolism, just across the board. Are there specific situations, we've already touched on that, where people might have an intolerance to some or all types of fiber? Yeah, there's always an exception in medicine. Ideally, look into it, see if you can reverse the condition so you can tolerate those foods again. If you can't, you do what you got to do. But for the majority of people, crystal clear, you want to eat foods that contain fiber naturally, and a diversity of them. Because when we talk about fiber, there's thousands of types of fiber. Some haven't even been identified yet. So it's not one molecule. It's this huge family of molecules. And there seems to be a benefit to including a diversity. So, some fruit, some whole grains, some legumes, some leafy greens. Ideally, this variety is going to, diversify your portfolio, as it were. I think it's for fiber for the majority of people, and in a Western population, it's critical. One of the main shortcomings of the typical Western diet is fiber consumption is too low. You can't find a professional scientific organization tell you that, and doesn't tell you to try to up fiber intake. The recommendations in the U.S. are to try to be above 30 grams a day, and the average intake is 15, and 30 is a low bar. So for a Western population, eating more foods that contain fiber, you can't go wrong with that.
Yeah, completely agree. We've touched we've done a lot on diets, and I think it'll be quite good to sort of segue into supplements and medications. And one of the medications that I do want to talk about with you is statins. There's a lot of anxiety, I think, around statins, and people have been reading all sorts of things that statins are terrible for the body. They cause muscle problems. They cause problems with hormones. They don't actually help. When actually the evidence says the complete opposite to all of those things. So, but I think you do a particularly good job at going through the research of statins, and just explaining it in quite a cool, calm way. So I'm really curious to hear your thoughts and how you explain statins to your audience and to your patients.
Another contentious, emotional topic. We get a lot of heated comments when we talk about, but for me, it's not this emotional thing. By the way, and every time I talk about statins or cholesterol, I like to make the disclaimer, because people ask, "Are you making money off of this? Do you have does your brother work in industry?" I don't make money prescribing medication. Actually, never have. Don't have any links to industry. That's not to say that somebody who prescribes statins and gets payment or does consulting for industry is necessarily what they're saying is necessarily wrong. But it's just easier for me to make the disclaimer so that people aren't conflicted with that. So the evidence, briefly, the evidence on statins is vast. There's just these two chapters. There's the efficacy and the safety angles. For efficacy, statins unequivocally lower cardiovascular risk. To give you specific numbers, when you look at meta-analyses of these trials, 22% reduction in cardiovascular events over 5 years per unit per millimole per liter reduction. If you're in the US, for example, we measure it more in milligrams per deciliter, and that's about 38. So 38 points that you reduce in your LDL cholesterol over 5 years, a predicted 22% lower risk. Now, there's all kinds of qualifiers to this. The risk at baseline, if you have more risk factors, if it's primary or secondary prevention, if you've already had a heart attack, then you stand to benefit more by taking statins in terms of absolute risk. And then kind of the time of follow-up determines also a lot of these numbers. But there's no doubt that for people at risk, at sufficient risk, and there's all kinds of algorithms to calculate this and to decide who needs statins. It's not passed out like candy, precisely because there are risks. Every medication, every intervention has side effects. Statins are no exception. They do have some documented side effects. The risk of onset of new onset diabetes, so basically of developing diabetes during the course of the treatment, is higher overall for statins over placebo. The qualifier to that is that it depends on the class of statins. So some classes of statins raise risk of diabetes, some don't. Some in some analyses actually lower it a little bit, so it's very heterogeneous. The dose makes a big difference. So very high doses of statins that actually now are no longer 80 milligrams. Not a lot of people prescribe that anymore. I don't know what you normally prescribe your patients, but it's typically seen that with lower doses around 10, 20, these effects are either absent or much more mild. And so those are two of the big qualifiers there. And the other big qualifier is that there are lipid-lowering treatments that are not in the statin class that don't have this effect of increasing diabetes, like PCSK9 inhibitors and ezetimibe. And I started with the diabetes not because it's the most common one, but because it's perhaps the most feared. And so I think it makes sense that people are wary and that people look into the information and don't just jump head first. That's what I would do if I had to take them, or if I had to give them to somebody that I care about. I would look at the pros and cons, and risk-benefit analysis always goes into this. So if it's somebody who is at risk and who can't lower their lipids with lifestyle, or if it's secondary prevention, for example, yes, it is indicated to give somebody a lipid-lowering treatment. And what you're going to do is you're going to play with these factors. The other thing that's very important to mention, it's not everybody that's at risk of developing diabetes. It's only people who have risk factors to begin with. So if you're already at risk of developing diabetes, statins seems to accelerate that process. So for that group of people with the risk factors present, you're going to play with all these factors, maybe work with your cardiologist or your doctor to try a statin class that does not raise risk, or you're going to keep a close eye on your glycemia. So you're gonna play with all these factors to maximize your benefit. In terms of muscle symptoms, that is the number one most common. And there are a number of analyses. There's a Samson trial that showed that actually about 80-90% of the people who have muscle symptoms, the placebo is indistinguishable. So it's not an effect of the drug itself. It's an effect of, well, it's psychological, but it's tricky to say that. People think that we're saying that they're making it up. The symptom is very real. It's just not the drug that's causing it for the majority of people. I believe that there's a small class, a small cohort of people that do have legitimate effects of statins. But my advice would be, if you have those symptoms, work with your doctor. There's many other classes of statins that may not cause those problems. You can also try a lower dose of the statin, maybe with one of these other newer drugs like PCSK9 inhibitors that don't cause nearly as much muscle symptoms. So there's all kinds of options. My take-home message would be, don't be too scared of these things, so scared that you just leave them completely out of the equation and you don't even consider them because the benefit, when they're well studied and well considered, the benefit is largely outweighs the risks.
Yeah, yeah, absolutely. Thanks for that. And there's a few things I just want to add. So we've got a comment here saying you can't have high cholesterol if you eat like you're supposed to eat. And I think that's a myth, right? Like, yes, there's some people that are eating a terrible diet and that when they fix their diet, their cholesterol will come down. I've seen that in clinical practice. But for the vast majority of patients that I deal with in the clinic, they're already trying to eat a healthy diet with, lots of fruits, vegetables, a wide variety of whole foods, and their cholesterol is still high. And in those instances, I don't shotgun just start prescribing statins, because at the end of the day, what we're trying to do is lower cardiovascular risk. So cholesterol is just one part of the overall picture as to what is that patient's risk of having a heart attack. So what we do is a score that works out their heart attack risk over the next 5 or 10 years. And we look at things like blood pressure, their weight, their blood sugar levels. Do they smoke? How much alcohol do they drink? It factors in all of these things to come up with a best guess as to what this patient's risk is. So I've got a few patients that have got, moderately high levels of cholesterol, but their cardiovascular risk is about 2% over the next 10 years. So they've only got a 2% risk of having a heart attack in the next 10 years. So for those patients, it doesn't really make sense to put them on a statin, because the benefit that they're going to get is incredibly small. Whereas other patients that have actually got normal cholesterol, they might be smokers, they might have high blood pressure that we're struggling to control, that they might have other factors that actually increase their chance of having a heart attack in the next 5 years of, 15%. And in those patients, even though they've got a normal cholesterol, we'll still be prescribing them statins, because we know from many different studies that it does lower their cardiovascular risk. But the thing that I want to try and emphasize to the viewers here is that it's the whole picture. Cholesterol is not the one and only thing that we need to focus on to lower the chance of heart attacks and strokes. Yes, it's important, and it's an important part, but it's not the whole part. So when I'm talking with patients about the risks of statins, I do mention the thing about diabetes, but overwhelmingly in the studies, when statins are used correctly, the risks of diabetes is overwhelmingly outweighed by the benefits of statins, again, when it's used correctly. And when people are concerned about hormones, for example, because statins work on the liver to stop the liver producing so much cholesterol, so they get concerned that it's going to cause issues with hormones. I show them multiple studies that looked into this, and actually in men, there's no difference with testosterone levels on with statin use, and that seems to put their fears at ease. And I think that's the thing. At the end of the day, I'm there to talk with my patients about the potential benefits and risks. I'm there to show them the evidence. And at the end of the day, it's up to them to make that decision. And it comes, just like diets, it comes back to informing patients so that they can make their own choice about what they want to do. And when I go through that process with patients, generally that they elect to go for statins, because I bring statins up with patients that I feel probably should be on it. And once I go through the evidence with them, and particularly around benefits and risks, generally speaking, that they go for it. So yeah.
Yeah, I would agree with the gist of what you said, and just to echo what you said in terms of the comment, I think what he's saying is based on some truth, that for a lot of people, I don't know exactly what the percentage is, but for a lot of people, lifestyle will be enough to bring our lipids to the healthy range. But there are clearly some people for whom it's not enough, and they have genetic constraints. They might have, in the most well characterized and one of the genetic conditions is familial hypercholesterolemia, right? So you can eat, you can eat whatever you want. Your cholesterol is not going to come down to 80 or anything like that. If you have homozygous FH, it's going to be through the roof generally. So the drugs are there for those patients. You have to offer them that option. You have to try to medicate. for people who can lower their cholesterol with lifestyle, you also have to bring into the equation that not everybody wants to make these changes and sustain them. So some people might prefer to take a pill than changing their diet for the rest of their lives, and that's their prerogative. I think we have to give them that option and respect their decision. In terms of the statins, I completely agree with you. You don't prescribe statins automatically for cholesterol that's above the threshold. The counterpoint to that is that the 10-year risk can be low, but then going further, you can see an increase over 20 or 30 years, even for people who don't have additional risk factors. So there are some leading experts who argue for more of a focus on ApoB measurements and less on these algorithms of the 10-year ASCVD risk. But so briefly, what I would say is that yes, you don't prescribe statins automatically for somebody who's, I don't know, who has an LDL cholesterol of 110 or something like that. You don't automatically, oh, statin. No. Once you get to very high levels, then it's pretty much automatic that a statin is indicated above 190 in the US. I don't know what it's like in New Zealand. But yeah, that would be my take home message is you don't automatically need a statin for those levels, but I would recommend focus on lifestyle for anybody who's got frankly elevated cholesterol, because for most people you can bring it down substantially with some lifestyle tools. Again,
Yeah, agreed.
not everybody.
And on the point of risk, so one of the things that I'm often encouraging my patients to do, if it's a financial option for them, if we want to get a bit more clarity about what their actual risk is, I'll refer them for a CT calcium score to actually image the blood vessels around the heart to see is there any calcium buildup, and that gives us a far clearer picture as to the risk of a heart attack. Now, I want to be clear that just if someone has a CT calcium score of 0, as in you can't see any calcium buildup, that doesn't automatically mean that they've got a 0% chance of having a heart attack, because there's non-calcified plaque that can build up in the blood vessels. But it does give us an overall interesting marker as to the risk of the patient that I'm treating in front of me. That if someone does have no calcium buildup, they do have a far less likelihood of having a heart attack compared to someone who's got lots of calcium buildup in their blood vessels. So that's something that I've been routinely suggesting to my patients. And again, it does come back to that overall picture that yes, lifestyle is crucial, exercise is crucial, but then sometimes we need to add in a few other things to help out those good habits that people are already doing.
There was an interesting piece.
On the point,
I was going to say there was a really interesting piece in JACC, the Journal of the American College of Cardiology, and it was an editorial comment on a study that they did on the calcium score, and they called it the fallacy of the power of 0, because there's this idea that if you have a 0, you're protected. There's a little fairy on your shoulder that doesn't let you, and it's not like that. There are a fraction of heart attacks and events happen in people with a calcium score of 0, so it's not a guarantee, but it is absolutely, no doubt, a valuable tool to separate, especially with people who are around the threshold where you're trying to decide, does this person, is it indicated to give a statin or not? A lot of times the calcium score in that range can be helpful.
Yeah,
it has a lot of prognostic value. Yeah,
that's right. Switching gears, one of the questions that was often coming up when we were planning this podcast is multivitamins. So I've seen a number of influencers online, I suppose, talking about the value of multivitamins. Now, the teaching that I had during medical school was that we should be focusing on a wide and varied diet, because if you do that, you're going to get all of the micronutrients that you need, and that there's no evidence that multivitamins have much of a role to play. Again, with the caveat that you've got a normal digestive system where you're absorbing, nutrients from your food, and that you've had a good diet. So I personally don't use a multivitamin, and I don't promote it on the channel, but I'm curious to hear what your thoughts are on it.
In general, that's my impression as well, that I wouldn't say that everybody needs to take one. My approach to vitamins in general is, if you have a vitamin deficiency in a specific vitamin, then absolutely taking a vitamin and topping that up can be helpful. Also, if for some reason your intake of a vitamin or a nutrient isn't adequate, it could be for different reasons, dietary options. It could be sometimes elderly population isn't eating, appetite issues. They eat a little lower, smaller amount of food, and there might be issues getting enough nutrients. In those cases, kind of as a complement of topping up that intake, I think it has value, it has place. I haven't seen evidence that to persuade me that every citizen should be on a multivitamin. I'm open to it if there's compelling evidence out there. I'm open to contrary evidence, but I haven't seen, and I've seen some studies that that just prescribing these things by default doesn't do much unless, again, there's these specific risks at baseline that is not necessarily helpful, and in some cases might even have some risk associated, not to mention the costs. So yeah, I would generally agree with your view.
Yeah. And chat, let us know if you've got any questions about multivitamins. I'm sure we can answer them. On the point, though, of trying to supplement particular vitamins or minerals that we might be low on. So one of the things that I've seen you speak about on your channel is vitamin B12. But I'm curious to hear your thoughts about, so I understand that you supplement with vitamin B12?
Yeah, I take it once a week, yeah.
Yeah. And what's the evidence to support that?
Well, just for people, either for people who don't eat a lot of animal products, it's beneficial. So you get B12 from three sources essentially: animal products, fortified foods, or a supplement. Those are the main sources. There are some other more controversial sources. Some people talk about different algae and duckweed and stuff, but those are tricky. A lot of times they're not functional forms. So those three are the reliable forms. For most people that are healthy and are on a typical omnivore diet, you're not going to need it. If you have an underlying issue or above a certain age, there are issues with B12 absorption, and even people who are on omnivore diets might need a bit more, might need a little supplement of B12. Has to do with the acidity of the stomach that is lost with age, and so you get less effect at breaking down the B12. But in my case, it's just because I eat a very small amount. I try to favor as many, get as many of my calories and nutrients from plant foods as I can, and so I don't know that I would necessarily be getting enough B12 from the occasional thing with dairy. That's the other thing, is that animal products are not uniformly good sources. Fish, meat, those things are good sources, but the vegetarian sources are not. So eggs and dairy are not good sources, either because they have very low amounts or the absorption, the bioavailability is very poor. And so for me, it's just easier to pop a pill once a week. But it's not something that I think every citizen needs to be on. Absolutely not.
Yeah, I think that's a really crucial distinction, that because of your diet that you're possibly going to be a bit low with vitamin B12. So it makes sense for you and your lifestyle to supplement it. And it's a similar thing with what I do with vitamin D. So I know that I work indoors most of the time, and whenever I go outdoors, I'm wearing sunscreen. So I know that if I didn't supplement with vitamin D, I would be low. And so I supplement with a small dose of vitamin D. Now, I do want to clarify, because I've been looking, and I'm going to make a video about this shortly, with vitamin D dose. So I used to take about 2,000 units a day, and I've re-looked at the guidelines, and also on the safety profile of vitamin D, and I'm going to reduce my dose slightly to 1,000 units. But a video will be coming out on that shortly. But again, I think it's all about that personalization. Again, you know that you're going to be low in B12, so you supplement it. I know I'm going to be low in vitamin D, so I supplement it as well. One of the other things that I also supplement, because it's tricky to get all of the to hit the daily requirements, is zinc. So for men, the daily requirement or the recommended intake is 15 milligrams. So I know that it's tricky to reach that. So I take 8. And I think you corrected me on the skill that the meta-analysis that I was looking at to support zinc use to reduce the common cold. So it was a Cochrane review that was actually retracted. So I need to make an updated video on zinc with that information. But I believe there are still a couple of randomized controlled trials, yes, not meta-analyses, that do support the idea that we do want to be hitting that ideal zinc intake. But on the point of supplements, are there any other supplements that you take outside of vitamin B12?
I take vitamin D sporadically. Depends on the weather, where I'm at, and how much time I'm outdoors. But I'm not super religious about it. And then I take a DHA EPA. Those are the three that I take off and on. The B12 is the one that I'm most rigorous about. The other two, I'm not convinced that especially the DHA EPA, I'm not convinced. I'm not married to it. I'm not convinced that it's definitely beneficial. It's just I haven't seen any compelling evidence of harm, and I've seen mixed evidence of benefit, so I take it. It's kind of a educated guess, if you will.
Yeah. On the point of omega-3, for me, I take it because of the results from the VITAL trial, where there was a reduction in the onset of heart attacks. It didn't stop deaths from heart disease, but it did seem to be associated with a lower risk of having a heart attack. And I also take it because of a meta-analysis from the Mayo Clinic published last year, where this meta-analysis was different because it only included studies that involved supplementation of omega-3 and compared it to placebo. So a few of the other meta-analyses, they included studies that only looked at dietary advice. So since we're dealing with supplementation, or whether we should be supplementing, that's why I think this Mayo Clinic meta-analysis holds a bit of weight. But as you say, I don't think there is mixed evidence and there's mixed opinions. There does seem to be quite a good safety profile with omega-3, particularly if it's not mega dosed. So yeah, I think it's reasonable to be taking omega-3.
Yeah, I looked at the Mayo analysis. When we chatted, you brought that up, and I included that in the video that I published where we were talking, and I went through it. And yeah, it's definitely compelling in and of itself. There's other metas that don't find the same thing, but it's an argument. It's a valid argument for considering a DHA EPA. And then the other outcome that people sometimes bring up is cognitive function. And I've looked at several trials of EPA DHA supplementation for cognitive decline to prevent it or to delay it. And there also I see mixed evidence. Some trials find no, and some analyses find no benefit. Others do find a benefit in delaying or avoiding cognitive decline. Usually when there's this sort of heterogeneity, sometimes it's dose, sometimes it's the context, if people are at risk or not. It's also baseline, serum levels. There's all these variables, right? These moving pieces that make sometimes the question a little harder to answer. But yeah, because there's this heterogeneity, I think neither position, and I've heard both, and I don't think either one's absurd to say, well, I'll take it, or to say no need. I've heard good arguments for both sides. I have colleagues who say, unless you show me good evidence that there's a deficiency in these circumstances and that I should be taking it, I don't see a reason. And I think that's a valid argument too. So I think it's one topic where there's some gray area. It's not crystal clear. And I think we're definitely going to see more evidence on this, and our positions may change.
Yeah, and that's exactly it. It's our job, I think, to relay information both to our viewers and to patients what the latest clinical research is, be it for or against. Because at the end of the day, it's just the human clinical studies that matter. Our opinion doesn't. Well, I think our opinion doesn't really matter. It's what the clinical research has to show. One of the other supplements that I personally take, and I've seen it come up in the chat a bit, is creatine. So, am I correct in saying you don't take creatine? Is that correct?
I don't supplement, but I'm open to it. I've certainly seen evidence for the athletic benefits, and it seems to be widely recognized as pretty safe. So I'm open to the argument. I'm open to the evidence. Pitch me on it.
Well, so I first started experimenting with creatine in high school. This is when I was training for different sports and whatnot. And I certainly noticed almost immediately when I started creatine working out at the gym, I could lift more and I could run a bit further and faster. So I don't think it was placebo, but hey, And the human clinical studies seem to justify the fact of creatine supplementation. That there's been various sports bodies in their guidelines that they overwhelmingly say that yes, creatine supplementation does have a role to play, particularly with muscle recovery. So I think that and back in the day, there used to be safety concerns around creatine, particularly looking at the kidneys. But it seems that those worries, it's been well studied over a 5-year period. There's no evidence that creatine speeds up kidney disease progression. So I take creatine about 5 grams every day, both on days that I work out and also days that I don't. Again, it's to protect my muscles while I'm working out, to help with my muscle recovery, and also because I feel that I can do more at the gym when I'm working out, and the studies seem to support that as well.
This
One
is
of the downsides that I've heard with creatine, and I haven't necessarily looked at this, is that it contributes to baldness. But I haven't necessarily looked into studies at that. But I know some people are very worried about that, so maybe I need to do a video.
Yeah, for me,
Are there any
the
other?
kidney
Oh,
angle
sorry.
is, I have a family history of kidney disease, mothers and grandmothers and stuff, and so that is something that I would look at very carefully for me if I was considering uh, supplementing with creatine. And for me personally, just the athletic benefit might not tip me over the edge, especially if I have any lingering concerns with kidney health. But that again, that's a good example of like making a personal decision based on the pros and cons and looking at the evidence and just deciding what's right for you.
Yeah, absolutely. It's that personalized approach, and I hope that everyone watching this video is understanding that just because we do something doesn't mean that you should, and it's about coming up with strategies that you can do over the long run that are overall healthy. A few other supplements that I think would be worth talking about. What not supplements per se, but it is hormone replacement therapy. So for my postmenopausal women that I see in the clinic, who are suffering with symptoms, before the age of 60, I'm routinely prescribing them estrogen, and if they need it to protect their uterus against uterine cancer, I prescribe them progesterone as well. But I think that the hormone replacement therapy has started to come a little bit into men as well, because we know that over time men's testosterone levels will decline, and so that's led to a lot of people starting to supplement or inject themselves with testosterone replacement therapy. Have you had much experience in this field or looked into the research much?
I did. When we talked, you brought up the testosterone trials, and I wasn't familiar with them, but I went over them in the wake of our talk. So that's really cool, and I'm glad that I familiarized myself with those, because those are like landmark trials, and there's a very clear, again, an example of personalizing and making decisions based on this risk benefit. Very clear benefits in some populations, clear signals of harm as well, and signals of concern. So something that needs to be on a case by case basis decided. It wouldn't be like passing it out, for everybody, adding it to the drinking water. But yeah, I saw the testosterone trial, some interesting benefits with the sexual function, with cardiovascular. There was a concern with plaque, right? A concern with the soft plaque.
Yeah, so I think you're absolutely right that there shouldn't be any blanket rules that we make up, because for some men, testosterone replacement therapy is absolutely indicated. It's medically indicated, that they, for whatever reason, may have really low levels of testosterone, and the cause of that needs to be looked at, and then it needs to be treated because they are symptomatic. But for the vast majority of men, testosterone replacement therapy doesn't actually make sense. We can maintain healthy levels of testosterone by resistance training, by eating enough protein, and testosterone replacement therapy, it does carry significant risks, and you mentioned one of them before, and this has been borne out with randomized clinical studies where they can see that the group that was taking testosterone replacement therapy, they had significant increases in soft plaque. And that's the plaque that I worry about, because that's the plaque that tends to break away and block up the blood vessels, leading to heart attacks and strokes. So this treatment, for most men, won't actually cause them or result in significant benefits over and above resistance training, and it carries significant risks, again, with blood vessel health, and there's also a concern with prostate cancer. So I think it's about informing patients, though. If I see patients in the clinic that bring up testosterone replacement, it could be because they've heard amazing things online. And again, it's up to me to inform those patients about the risks and benefits and go through the trials with them so that they can make that informed choice. But for the vast majority of men that I see, testosterone replacement therapy should not be prescribed. The caveat to that is that it's different for women who are postmenopausal with estrogen replacement up until the age of 60. There seems to be good cardiovascular protection with that. It seems to protect their bone mineral density, and with minimal risk, again, up until the age of 60, so long as there's no contraindications such as previous breast cancer and things. So that I routinely prescribe, and I'm happy to, again, because the evidence supports it, particularly when I go through that evidence with my patients.
Do you find that
Yeah.
weight loss
Anything you want to add?
actually affects testosterone levels in your clinical experience, or it's a small effect?
So there's good clinical studies showing that weight loss in men does result in high testosterone levels. So I don't, the clinical guidelines that I follow from the Endocrine Society suggest that unless you strongly suspect a testosterone deficiency, as in a patient comes to you symptomatic, testosterone level should not be routinely measured, because they the benefits of testosterone replacement therapy for non-symptomatic men do not make sense. So they suggest to not measure it. So I don't have any anecdotal experience with weight loss and testosterone levels, but I know from the clinical trials that there is an improvement in testosterone levels with weight loss. And coming
Gotcha.
back to females with the estrogen replacement, I've seen it in clinical practice where you get these amazing results in terms of, the flushing goes away, people just generally feel better, their anxiety seems to resolve. It's personalizing it. We hormone replacement therapy for women in certain circumstances absolutely has a role to play. In men, it's a far lower proportion of men that would benefit, but for those men, there's absolutely a role to play for testosterone replacement. But for the vast majority of men, it doesn't have a role. But that's mirrored against the probably vast benefit that women would get from estrogen replacement therapy, again, when prescribed correctly. So yeah. Are there any other particular supplements that you wanted us to go through? Chat, also holler out if you guys want us to go through any particular supplements. Otherwise, we can move on. Otherwise, we can move on to fasting.
Okay, yeah, we can do that.
Yeah. So yeah, I think let's talk about intermittent fasting, particularly time restricted feeding. So I recently did a video about this because I think when time restricted feeding is done correctly, it can, and the clinical studies show this, it can result in some benefits. I'm just concerned that for the vast majority of people, they use time restricted feeding as an excuse to skip breakfast and to load up the calories in the evening. So I'm curious what your thoughts are, first of all, on intermittent fasting and how you have these discussions with your viewers.
So for me, as I went through the literature on fasting, it seems to me that there are two factors going on. One is fasting itself, and the other factor is the time of day at which you eat, the circadian effect of eating. And the fasting itself, just the not eating for an interval of time, when you look at the largest meta-analyses and everything put together, there doesn't seem to be any additional benefit on top of the caloric restriction, the caloric deficit. That doesn't mean that fasting can't be used and that it's not useful. I think it's an entirely valid way of managing your intake of foods. I have a lot of viewers who like to fast and who do very well on it. Um, I don't think there's a lot of hype on social media that says that you have to fast for autophagy, otherwise, you're going to be sick. There's no support. There's no evidence to support that there's an additional. I'm not saying that the autophagy is not induced. I'm saying there's no evidence that there's an additional benefit to fasting on top of the calories. So people who like to fast and who help, for people for whom fasting helps them control their caloric intake, great, use it. People who don't like to fast, you don't have to worry about it. As long as you have a healthy diet overall and a reasonable overall caloric intake, there's no evidence that you need to add fasting on top. That's the effect of fasting per se. Then the circadian effect of what time of day we're eating. There's a little bit of mixed evidence as well. I was more convinced up until very recently that it was more beneficial, that there was a beneficial effect there. Then there was this trial that came out earlier this year that suggested little to no benefit of the time of day of eating on top of just a caloric control. As I look at everything, I suspect there is a benefit of eating earlier in the day seems to be more beneficial as opposed to eating later in the day. There might be a little metabolic benefit, maybe a benefit in terms of insulin resistance, maybe a slight advantage in terms of weight loss. So for people for whom it's all the same or who like to eat earlier in the day, I think that makes sense. I like to emphasize that this is likely a small factor in the grand scheme. So by all means, eat earlier in the day if you like it, if it fits into your lifestyle. But the biggest bang for your buck is going to come from eating a reasonable amount of calories and eating quality calories. Those two are going to be, runaway determinants of your health at every level. And then a distant third, if you want to add the component of time of day and shift your calories a little earlier in the morning, early afternoon, and not load up too much at night and later during the night, I see no problem with that.
Yeah, I completely agree that the hype, I think, kind of ran away with intermittent fasting. That we don't have the slightly longer term studies that we do have don't really show much of a benefit with time restricted feeding, with the caveat that possibly there's a small benefit if we get more calories in the morning compared to the evening. So that's one of the things that I try and talk about, that I just don't want intermittent fasting to be used as an excuse to skip breakfast, because I think, if anything, that strategy is probably more harm than good. But yeah, I think there's still a lot of work.
I guess it depends what they're eating for breakfast, and if it helps them moderate their calories, it could tilt the scales.
Yeah.
I could see that if you're overeating and you have to lose weight, and if skipping breakfast, if you're not going to compensate later in the day, if the overall caloric intake is going to be reduced and it helps you lose weight, and skipping breakfast is the only way you can do it, I can see that having a net positive effect.
Yeah, I agree with that. That if patients want to use it as a way to restrict their calories, absolutely, and I fully support that. But if patients are already at a healthy weight, that are looking for that extra added benefit, that's more what I'm talking about. Where I don't think that skipping breakfast is a wise strategy. Yeah, what I'm particularly interested in is, so we've got very limited human evidence on this, so and that's what I hope gets fixed soon, is prolonged fasting, so multi-day fasting. That I think would be that I think is really interesting, with the caveat that I don't think people over the age of, say, 60 should be doing it, because I'd worry about their muscle stores. But for people younger than that, I'd be really curious to see what, if any, benefits there are of multi-day fasts. And again, at the moment, most of it is just guesswork and extrapolating from my data. So we cannot make any firm conclusions, but I'm excited for those trials if and when they eventually come out.
Yeah, I have not seen the majority of the careful trials I've seen were either short-term fasting or were the time day thing, or they were ADF, alternate day fasting, where you eat for 24 hours, you fast for 24 hours. That's the longest. Oh, there's some 5-2, 5-2. Yeah, you basically you eat for, or 3-2, but or you fast for 2 days essentially. I've seen some trials looking at that, and also didn't see a clear indication of benefit above caloric intake, of the caloric restriction benefit. But yeah, there's all kinds of programs and clinics that work with long fasting periods of a week and 2 weeks and a month. And I don't know, in terms of rigorous evidence, I don't have a strong opinion because I haven't seen any evidence one way or another, in terms of the risks and the benefits. Yeah, I'm open to seeing that.
Yeah, completely agree. So every 3 to 4 months, I'll do a multi-day fast. But again, there's no real human evidence to support that. I like the presumed mechanism, but again, it's not particularly evidence-based, and it's based on mice trials. So I'm interested to see what those studies show, and so I certainly don't promote my patients to be doing these multi-day fasts because, again, we've got no benefit. We've got no evidence of benefit, and there's possible harm. So yeah.
I'm on a
So
16-8. I'm on a 16-8 program of fasting. I fast for 8 hours a night, and then I eat during 16 hours a day.
love it,
Okay.
love it. So one of the questions that came up again while planning this stream was, what is Gil doing personally to live longer? So very curious to hear what your health strategies are that you're following day to day to improve your health.
I mean, it's the basics. It's the boring answer. Eating a careful diet as much as I can. Not obsessed, not to the point where you're pulling out your hair, but if I feel like eating a cookie once in a while, I'll do it. But I won't eat a sleeve of cookies a day. So a pretty careful diet. Exercise regularly, 4 or 5 days a week. Try to sleep. I don't limit my sleep. I'm really careful about that. I protect my sleep time. That's really the bulk of it. Try to manage stress. Try to have a positive outlook, and to kind of root this on evidence. As I look at most of the human evidence on lifespan, and this is interesting because actually my background in graduate school, a lot of the experiments we did were precisely looking at lifespan in model organisms. But a lot of the things that we found in model organisms haven't really been replicated extensively in humans. So a lot of the things that are published consistently that extend lifespan in mice and flies and worms and all these animals that are used in the laboratory are things like the insulin signaling pathway and the TOR pathway, and the effective temperature. But when I look at the human data, things that are consistent buttons and levers for longevity are the risk factors for the common diseases that we have. So it's cardiovascular risk factors. It's things that determine BMI, things that determine diabetes, your glucose metabolism, tobacco and alcohol. These obvious things, the classical risk factors that we've heard our entire lives are critical. That's been largely vindicated and reproduced in these studies, even in the more modern studies, the Mendelian randomization. I've seen a couple of those where basically it's a genetic technique where you're looking at people with different genetic variations, different polymorphisms, and you're comparing that to their longevity. And largely it has also confirmed so people who have genetics who favor their cardiovascular health, who reduce their risk of heart attacks, who lower their ApoB, who lower their glucose levels, who lower their blood pressure. These are the things that have come out significantly and consistently out of these studies as determining lifespan. So I'm playing with the lifestyle buttons to maximize those factors.
Yeah, and I think that's the crucial point, that yes, we can get excited about the latest, supplement or diet strategy or whatever, but longevity and sort of health and lifespan, it really comes down to those fundamentals of a wide and varied diet, regular exercise, good sleep, making sure you've got a purpose in life, possibly meditation, socializing with friends and family. Those are the things that actually make a difference to health and longevity. And it doesn't really sell books, it doesn't sell supplements, and that's fine, because most people can do those fundamental basics and get epic results. So yeah, I love the emphasis that lifestyle is really where the money is for longevity.
Let me add one
So
personal note on. I think I just want to make the point of consistency. So a lot of times we get over anxious and we want to maximize and get every dot, and the stress can actually undo some of the benefit. Maybe it's a net negative if we stress too much. But I'll give you a personal example. Last year was very difficult. We had a family health crisis of massive proportions, and so my health took a big dip last year. I had to let go of a lot of the things that I do that are centered on my health, to make sure that that I helped some family members that had just devastating, life-threatening situations. So my health deteriorated over last year. Am I stressed over that? No, I had to do it. It was worth it. Now that my mom specifically is much better, I just went back. I just went back to exercising. Went back to now I have the time to focus again on these critical factors, and I bounced right back at the gym, diet-wise. So the point is that a blip in the curve, a graph that lasts 60 or 70 years, and you have a blip, doesn't matter. What matters is the consistency over the long term. So sometimes we get too obsessed with the details, and we lose track of the big picture.
yeah, completely agree. So I just want to thank you for your time. I think this has been a really fun and hopefully useful discussion for the viewers. So yeah, if just viewers, if you haven't already looked at Gil's channel, so I highly recommend that you do. It's Nutrition Made Simple. He breaks down things in short, easy to understand snippets. So I highly recommend that you go and subscribe. But again, thanks, Gil, for coming on. This has been a lot of fun.
Thanks, man. It was a blast. Take care.